Good afternoon, everyone, and welcome to the Lynn Cancer Institute updates for 2025. We're calling our lectures now Important Information for Everyone. Our lectures are geared for our cancer patients and their caregivers and family and friends, but we feel this information is good for all of us. This series is featuring colon cancers from our physician panel series. And we're very grateful to have our physicians with us today. Dr. Andrew Ross, colorectal surgeon, Dr. Ross Taylor, our radiation oncologist, and Dr. Samuel Cariff, our medical oncologist. At the Lynn Cancer Institute, we believe that education, prevention, screening, and early detection, a variety of treatment options, the expertise of our staff, and our latest technology will truly save lives. In the interest of time, each physician's bio was sent to you by email. We invite you during the lecture to please take notes because any questions that you might have, any questions or comments, we ask you to please put them in the chat box or the Q&A. And there will be time at the end of the presentation for the physicians to answer your questions. Now, I would like to introduce and start with Dr. Andy Ross. Dr. Ross?
Hi, I'm Andy Ross. I'm a colorectal surgeon here at the hospital. And I really want to emphasize this morning or this afternoon the need for screening for colon and rectal cancer. Screening saves lives. As some of you may not know, many of you may not know, colon cancer occurs in 1 in 25 in the United States. It's a very significant health problem, and screening is probably the most important thing that I think that you can take away from this discussion this morning. Delaying screening can increase the risk of colon cancer. It's clearly on the rise in young people. This is a pretty amazing fact that by the year 2030, the leading cause of cancer death for people between the ages of 20 and 49 will be colon cancer. This is a clear change in the pattern over the years, and it's something that is vitally important to understand. 1 in 5 cases of colorectal cancer occur in people aged 54 or younger. It's no longer just the disease of older people. So who's at risk? Are you 45 years or older, which that appears to be the age at which we're starting to recommend screening? Do you have a family member who has a history of colon polyps? Or do you have a family member who has a history of colon cancer? Patients with chronic inflammatory bowel disease, such as ulcerative colitis or Crohn's disease, are also at increased risk. If you have a family member who has a history of ovarian or endometrial or gastric cancer, you may be at increased risk. Afro-Americans and Hispanic descent individuals also seem to be at increased risk. So screening can prevent colorectal cancer. Other things to consider are healthy lifestyles, obviously getting screened regularly at 45, exercise and maintain a normal body weight, plenty of fruits and vegetables and high fiber foods, avoid foods that are high in fat, alcohol, don't smoke, and drink alcohol only in moderation. How do we screen for colon cancer? You know, in our estimation, the gold standard is colonoscopy. All of the modalities have to be compared to colonoscopy in terms of accuracy. Not only is a colonoscopic evaluation diagnostic, it can also be therapeutic at the same time. If we find polyps, they can be removed. There are alternative methods such as DNA stool testing. As you know, the Cologuard test has been highly advertised on TV. While this appears to be simple, it carries with it a significant number of false positives, and we don't know how many false negatives. If a Cologuard is positive, you still have to go through a colonoscopy to make a diagnosis. One of the things we were just talking about a few minutes ago is that most insurance plans cover routine screening examinations nowadays. So a colonoscopy is a routine screening examination. If you have a Cologuard, which is also considered a routine screening examination, and that's positive, the necessary colonoscopy to follow up is no longer screening, and it probably applies towards your deductible. So it makes sense to kind of do the definitive procedure the first time. These tests are also not indicated for patients at more than average risk. In other words, an average risk patient is one that has none of the any of the other family history or personal history that I discussed before. So, symptoms of colon cancer. Colorectal cancer is often silent with no symptoms. Symptoms to be concerned about could be blood in the stool or on the stool. Most people think that blood in the stool is related to hemorrhoids. Any blood is abnormal. Any change in bowel habits. If you're normally constipated and all of a sudden start having more frequent bowel movements, that's a change in bowel habits. If you're normally have frequent bowel movements and started to have fewer bowel movements, that's also a change in bowel habits. Stools that are narrower than usual, and general abdominal discomfort, fullness, and cramps, all are potential signs and symptoms of colon cancer. Other symptoms include vomiting, frequent gas pain, weight loss for no apparent complication, as I said, rectal bleeding, and fatigue during activities that were normally well tolerated. This often would indicate an anemia, which might be a symptom of colon cancer. So, in my estimation, the most important thing to take away from this seminar today is that you need to be screened. Screening is somewhat anxiety provoking, but as anybody who's had a colonoscopy knows, the colonoscopy itself is almost anticlimactic. The prep may be a little challenging, but it can save lives, and that's the most important takeaway from this talk.
Thank you, Dr. Ross. Next, we will have Dr. Taylor.
All right. Well, good afternoon, everyone. Thank you for having me. I'm one of the radiation oncologists here at Lynn Cancer Institute, and I've been tasked with presenting some information about how we treat colorectal cancers, in particular, where radiation therapy falls along the treatment paradigm. But I, wanted to start with just talking a little bit about what therapeutic radiation is, because I think there's a lot of misconceptions about what radiation is, and sort of its benefits in regards to cancer care. Certainly, Dr. Ross's presentation was fantastic in really talking about screening, because ultimately, screening, if something is detected, it's usually caught at an early stage, which again can be beneficial on so many levels. And so we'll talk a little bit more about that. But when we talk about radiation, it really comes down to some very basic physics. I'm sure many of you remember this from grade school, the electromagnetic spectrum. And all this really is, radiation is energy, right? And so you have these large wavelengths that are sort of low energy radiation, like radio waves, microwaves. We get into the visible spectrum of radiation. So visible light is radiation. But what we use in the treatment of cancers is what we call ionizing radiation. So gamma rays, X-rays. They're packets of high energy that essentially can disrupt DNA. And so that's what we use. We use these elementary sort of physics to treat cancers. And so what this is showing is the biologic effects of radiation. So you have these high energy ionizing radiation photons, and they directly damage the DNA. So you see here they interact with a particle, and that particle, an electron, is released from the atom, and it actually is able to disrupt the DNA. And so in the context of a tumor, you disrupt the DNA, the tumor is unable to recover from that, and the cells die. The indirect damage is basically the same concept, except that electron that is released from an atom attaches to a water molecule, and that hydroxyl radical then destroys the DNA. So when we talk about radiation in cancer care in general, there's several uses for it. So we use it for definitive treatments, meaning that sometimes we can do radiation alone for curative treatments. Some examples here are cervical cancers, head and neck cancers, prostate cancers, and lymphoma. For colorectal cancers, we use it more in an adjuvant setting or neoadjuvant setting, which really means that we're using it in conjunction with other therapies. In the context of colorectal, it's usually surgery. So we'll talk more about the treatment paradigm because this is a talk about colorectal. And then, of course, this idea of palliative treatment, this can be used in all types of cancers to treat symptomatic sites. So where does radiation fit in the treatment of colorectal cancers? Well, when we talk about colon cancers, there's minimal role for radiation. Surgery is the mainstay, as well as chemotherapy plays a role. In select cases, radiation may be used in unresectable disease or those patients who aren't responding to chemotherapy. Postoperatively, radiation may be used if the cancer is involved with nearby organs or the surgery was unable to completely get rid of some of the microscopic cells. Where radiation really does play a larger part in the treatment of colorectal cancers is rectal cancers proper. So when we have early stage disease, those that are getting their regular screening and something's detected that's relatively small, it's not invading through the rectum, oftentimes radiation or chemotherapy aren't needed. It's surgery alone. But as we get into the more advanced stages, that are limited to the pelvis, this is when we start talking about upfront radiation with or without chemotherapy. And then, of course, we talked about palliative radiation when cancer spreads outside of the pelvis and we use radiation for symptomatic management. So here's a schematic showing sort of the big picture here of how we're treating a lot of rectal cancers in 2025. The highlight that I really want you to see, and I hope you can see my my arrow, let's see, is focusing more on the locally advanced because again, this is specifically about radiation, and this is where we as radiation oncologists play a bigger role. So those cancers that are localized but maybe more advanced within the rectum, we talk about this idea of total neoadjuvant therapy. And all that means, again, is treatment before a surgery. Oftentimes we see chemotherapy, immunotherapies involved, and Dr. Kuraf will talk more about that. But radiation is oftentimes indicated in these situations. Why do we do this? Well, the benefits have been shown through multiple clinical trials. The benefit is to shrink the tumor. So by shrinking the tumor before surgery, we can increase the chance of successful surgeries. In some cases, depending on the location, this can include sphincter preserving surgeries. We are able to reduce the risk of this tumor ever coming back. In the setting of lymph nodes, we're able to sterilize the involved lymph nodes in the pelvis. We lower the side effect profile compared to giving post-operative radiation. And there's this new sort of paradigm emerging about the potential for non-operative management. Now, it's something that still, clinical trials are looking at, but it's certainly something that's exciting moving forward. Radiation is quite a involved treatment modality. There are a lot of people, physicists, dosimetrists, therapists that are involved. We use a lot of cutting edge technology, including imaging for localization of the tumors, CT, MRI, PET scans, X-rays. We use multiple advanced techniques to get the radiation to the tumor itself, as well as preserving all of the normal tissues nearby, again, to really limit the side effects to those normal healthy tissues in the pelvis. Here's an example of what a classic linear accelerator looks like in terms of how we treat these sort of tumors in the rectum. You can see here that the beam sort of travels around, aiming at the tumor. And again, the idea here is to shrink the tumor to make it more amenable for surgical resection. When we talk about radiation, certainly we care about potential side effects. The most common side effects tend to be relatively mild, like fatigue, diarrhea. There may be some skin discomfort around the rectum or the anus. Less common would be nausea or urinary symptoms. But a misconception about radiation is we almost never see hair loss on top of the head. And during your treatment, you're not radioactive at any point during an external treatment. So, i.e., there's no risk to your family once you're going home from a treatment. After your treatment, the side effects tend to ease up in the weeks after. The effect of radiation on the cancer cells itself take about 2 months. So even after your treatment, the effects of radiation are working to continue to shrink these tumor cells and kill these tumor cells. And once we're done, we usually get a restaging MRI to assess the response, followed by surgery around 6 to 8 weeks after. This allows for time to heal from the radiation itself and for maximal tumor response. I'm happy to ask questions at the end. I think Dr. Cariff has some information about chemotherapy and immunotherapy.
Yes, thank you so much, Dr. Taylor. Dr. Cariff?
Yes, thanks all. Let me go ahead and share my screen here. Okay, great. So first of all, apologies for joining a couple of minutes late, busy clinic morning, but I just want to say one thing, and I'm not sure if it was mentioned at the introduction, but I'm listening here to my colleagues, Dr. Ross and Taylor, and not only do our messages or not only are they united here, but I think it's just so important that patients with various types of cancers, including colorectal cancers we're talking today, be evaluated by a multidisciplinary team at a place like Lynn Cancer Institute. It's so important that we're all kind of incorporated into each treatment's paradigm and making sure that each patient's case is discussed at length, and that is something we offer here, and I'm just very honored to be part of this panel today, so thanks for organizing it. So as I reflect, Dr. Ross first talked about screening and how important it is, and I couldn't agree with that take-home message more. Please go ahead, get your Cologuard, get your colonoscopy, even go for the new liquid biopsy screening if that's offered to you, because this is very important. And then as Dr. Taylor was kind of commenting on the use of radiation therapy, specifically in rectal cancer as part of a surgical paradigm, what I'd like to chat with you folks today is a little bit about the advancements that we've had in our medical oncology clinics in the treatment of colon and rectal cancers over the past really 5 to 10 years. It's been a very exciting time in our field. We're in the era of what we call precision oncology, making sure that we have the right drug for the right patient at the right time. And I'm going to share a couple take-home points that I hope I can leave with you folks today through just a couple of slides without getting too much into the weeds here. My first take-home message before we start is biomarker testing is imperative. I actually believe this for all cancers, but especially for colon and rectal cancers, which is what we're talking about today. So this first little graph that I'm showing you here is related to the diagnosis of metastatic colon and rectal cancers. And what you can see is that we have to look at several types of genes at the time of diagnosis to make sure that we are treating patients with stage 4 disease adequately. You can see I've listed some here, names like BRAF, KRAS, HER2, NTRK, RET, etc. Obviously, no one needs to memorize this or commit it to memory, but it's important for us in the clinic to know your status, or at least your tumor status, before we start empiric therapy, because this significantly affects what we recommend for you in terms of targeted immunotherapies. I can't tell you how many times in my clinic a patient's first question to me is, I'm not super excited to see you, but I'm willing to go ahead with treatment. What can I do in terms of targeted immunotherapy? I want to avoid chemotherapy at all possibility. And indeed, that actually can be a reality for a lot of patients with these diseases. You can see in the last column here, there are several targeted therapies like encorafenib, which is a pill which is given for this BRAF mutation, or adagrasib and sotorasib, which is a pill given for this KRAS mutation, or this list of immunotherapies, pembrolizumab, nivolumab, and ipilimumab, one that's not listed here, dostarlimab, for patients who have what we call deficient mismatch repair or microsatellite instability high tumors. And again, this is speaking to the power of genetic sequencing when making sure that we're offering the right treatment for the patient's tumor. So basically, what I'm trying to impress here is that it's so important that we get your biomarker testing at the time of diagnosis, and unfortunately, if there's progression of your cancer down the line, to ensure that we're treating the right clone of your tumor and making sure you're getting the best FDA-approved therapy, which has been studied in detail prior to us offering it to you here in the clinic. The next sort of take-home point, which I alluded to already, is that there are so many options beyond traditional chemotherapy. So if the last slide I scared you with this little flow chart, I really hope I don't scare you with a slightly more nuanced than the electromagnetic spectrum that Dr. Taylor showed us a few minutes ago. But this is basically what we learn in our medical oncology training, looking at all of the targets that are available for tumor cells and wherever they happen to be within their progression. So without going too much into the details here, I just want to highlight a couple of options that are beyond what we call these traditional chemotherapies, and these are also, in a lot of cases, targeted therapies. In the middle of the slide, you can see here that KRAS and that BRAF mutation I've already alluded to, which is important information we try to get at the time of diagnosis, for which we have oral targeted therapies, which are pills. Let me highlight here on the top of the slide this HER2 receptor, which is currently here in a colorectal cell. Now, for many patients here who are listening who are either being treated for breast cancer or for breast cancer survivors themselves, they might say, hey, I've heard of this before. My breast cancer demonstrated HER2 positivity, and I was a candidate for drugs like trastuzumab or pertuzumab previously. Well, indeed, we actually have found that in a lot of colon and rectal cancers, this HER2 can be expressed in high concentrations, such that targeted therapies like pills, tucatinib, lapatinib, or IV therapies, trastuzumab, pertuzumab, or a very new drug on the block, trastuzumab deruxtecan, can be given to help patients kind of get some tumor shrinkage, especially at the time of diagnosis. Similarly, you can see that there are other mutations which maybe for patients with lung cancer who are listening on the call today might have said, I've heard about this EGFR, I actually take a pill for my lung cancer. Well, we target the same receptor a little bit differently in colon and rectal cancers with targeted therapies called cetuximab or panitumumab. The same idea here being that if we block these things, we can try to decrease the growth and progression of patients' primary tumors. Finally, on the left here, I'll comment on a third molecule called VEGF. This is a molecule that's been implicated in various cancers like colon and rectal cancers, also cancers of the central nervous system, etc., where we have targeted therapies, both in the forms of pills like regorafenib and a newer drug on the block, as well as IV therapies, bevacizumab, also known as Avastin, for which a lot of our patients are receiving these sorts of therapies. So when someone asks me, are there options beyond traditional chemotherapy in the clinic? Absolutely. This either can go solely for the treatment of a patient's cancer or can be complementary to traditional chemotherapies to make sure that we are really eradicating the cancerous clones as much as possible. The last thing I want to leave you with, and I also foreshadowed this just a touch in my introduction, is we have a very exciting new development in the clinic called a liquid biopsy. So let me take a step back. A liquid biopsy is basically a blood test which looks for circulating tumor DNA or circulating tumor cells themselves to see if they are going around in patients' blood near or after diagnosis, such that we can get an idea if there's any molecular residual disease at play. What do I mean by that? Basically what it sounds like, any molecules related to tumor in the form of shedding or leftover tumor after curative surgery, for which we may need to escalate or continue therapy beyond what we might have thought previously to the rollouts of these tests. So there is a now FDA-approved assay that is used for a lot of patients in the adjuvant or after surgery setting, looking to see if there's any DNA that is positive during these treatment months. And what I want to show with you is actually brand new data that was presented at our medical meeting just a few weeks ago called ASCO GI, in which we saw that these MRD status was actually linked to outcomes for patients receiving adjuvant therapy, specifically for colon cancer in the population that I'm demonstrating here. So let me show you the upside. Look on the right of the screen where it says MRD negative patients. We actually found that for patients who were MRD negative, meaning that we didn't see a lot of DNA related to a patient's tumor circulating in their blood, they actually did just as well as the patients who were observed. Now, is this applicable data for every patient case? Absolutely not. And there's a lot of nuances to these data, and that's the reason why you'd establish with a medical oncologist to discuss this in detail. But for this select patient without high-risk features, earlier stage disease, etc., foregoing adjuvant after surgery chemotherapy can be an option. And I do rapidly anticipate these outcomes being incorporated into our national guidelines soon. Let's look to the left, MRD positive patients. Okay, so what we see here is a couple things. You can see on the graph that for patients who are observed versus those who get adjuvant chemotherapy, in this plot we call a Kaplan-Meier curve, meaning that as things go down the steps, so to speak, outcomes are worse. We know that foregoing chemotherapy is not an option here. And indeed, for most of our patients, this is already recommended by national guidelines. However, not only do we recommend continuing adjuvant chemotherapy as we have already kind of established in our treatment paradigm, we see that these patients do better, meaning that they don't have a recurrence of their disease as indicated by this kind of stepwise decline occurring less rapidly. So you can just see how this liquid biopsy is so important in playing a role in making sure that we've got the right adjuvant treatment paradigm, especially for these patients who have thought to undergone curative intense surgeries offered by folks like Dr. Ross in hopes of making sure disease doesn't come back for as long as possible. So wrapping our medical oncology presentation together, I want to leave you with the three take-home messages. Biomarker testing is imperative. Indeed, I order it for all my patients. There are options beyond traditional chemotherapy, and that kind of builds on the take-home message 1 here, and you can see some of the options I discussed with you in brief today. And option 3, there's an evolving role to liquid biopsy. Indeed, for a lot of patients, we can actually forego chemotherapy in a lot of cases, depending on cases and features specific to that patient's tumor. Thanks so much. I'm happy to take your questions.
Thank you, Dr. Tariff. I just have to say thank you to each of you, and to say that this was amazing education is an understatement. And prior to the presentation, Dr. Ross and I were speaking about just what to do, and for me, what to do out in the community. And his response was awareness and education. Of course, the screening tools, but we can't get to the people without this type of education. And I think what each of you have given us today is a tool that those of us that work in other areas at the Lynn Cancer Institute can certainly use. And I've already gotten one request for a copy of this lecture. So great job. We're very, very grateful to each of you today. And we appreciate how much goes into preparing this presentation and the value of your time today. So to the audience, all these lectures are recorded, and this presentation will be available for you to look at again for your own education or to share with family and friends. And Lee will be sending out a survey. We appreciate your response on the survey. It helps us to build our database and also to know where we can answer any of the questions that you have or bring you education that you're looking for. So we appreciate you returning that to us. Thank you for today, and we want everyone to know about our presentations that we will be offering on Zoom in April. On April 2nd, our survivorship series will be presented by the Reverend Guillermo Escalona. Many of you have seen many of the LCI and Boca Regional employees have seen this on our emails. The lecture will be Thriving, Empowerment, Engagement, and Resilience. On Wednesday, April 9th, our nutrition series will be culinary pharmacy. The speaker will be Marie Mirande, our oncology clinical dietitian. And on Friday, April 11th, our physician panel series on head and neck cancers. Our speakers will be Dr. Micah Glahn, Dr. Ross Taylor, again, thank you, Dr. Taylor, and Dr. Mathen Matthew, and Brandy Hyatt, are another oncology clinical dietitian. On Wednesday, April 16th, we will be offering the power of advanced care planning, and the speakers will be two of our licensed clinical social workers, Elsa Rayner and Ann Williams Nicholas. This month, I want to note that in our department, we're celebrating our social workers. It's National Social Work Month, and also dietitians. It's National Dietitian Month. So, and of course, Colorectal Cancer Awareness Month. We have two questions. Let's see, one on the chat box. Can you see this? I'll read it and then the appropriate physician. What is immunotherapy Oh, why is immunotherapy restricted to metastatic cancer?
I'll take this one. Thank you for your question, Robert Cole. So actually, immunotherapy is not restricted to metastatic cancer. Indeed, there are uses in the locally advanced setting, and I think Dr. Taylor was alluding to this a bit in his conversation related to evolving clinical trials, but there actually have been novel applications of neoadjuvant or before surgery immunotherapy resulting in very impressive complete response rates for rectal cancer specifically. So the short answer to your question is it's no longer restricted in that area only. This is a very nuanced question. These approvals by the FDA need to be applied to each case very specifically. Moreover, need to be discussed in venues like our multidisciplinary tumor board, but we can use these occasionally in locally advanced disease states like rectal cancers as well. Thank you.
And there is one more question. Do you have a specific company that you use for liquid biopsy?
Thank you, Polisiski. I will also take this question since I brought it up. So, rather than specific vendors, I actually want to just kind of make a little distinction for folks understanding the role of liquid biopsy, specifically kind of educating folks on what we call tumor-informed versus tumor-naive liquid biopsy applications. I alluded to it a little bit in my presentation, but tumor-informed liquid biopsy applications are those that take the DNA and molecular makeup of a patient's primary tumor and then compare that to any residual DNA that may or may not be circulating in a patient's blood. So to that end, there's a very commonly known assay called Signatera by a company called Natera, and this is often used in colon and rectal cancers to get that prognostic and sometimes predictive information. There are other types of assays that are tumor naive, meaning that they're just looking for any sort of DNA that is currently circulating through a patient's blood. Let me give the example of the Guardant vendors platform called Reveal. At this time, this is just looking for any residual DNA that may or may not be present, though it's not tumor informed in the sense that it doesn't use that tumor specific tissue expression to see if that DNA is related. To be very fair and free of commercial bias, I am aware that this vendor is making a more tumor-informed assay, which is not yet available for commercial launch. But as you can see, this data and science are evolving rapidly, and we do expect that mostly all of these assays would be tumor-informed moving forward.
I think that's it as far as the questions. And so thank you, doctors. We're very, very grateful to each of you and appreciate your expertise and generosity of your time. Have a good afternoon and good weekend, everyone.
Take care.
Thank you.
Thanks all.